Good evening, ma'am, and very good evening.
Criteria Eye Hospital and Research Institute, Trivandrum, and she has a wonderful video to show. She is going to tell us something new about femtocataract.
Membrane matters in flaps. The first membrane encountered in the eye during flax is the decimes. So we'll start with the decimes membrane. Here's a laser section being made on the cornea. You can see how an air bubble starts at the inner lip and expands onto the central cornea. This has caused the decimes membrane to lift off the cornea and create a potential space, as evidenced by that unmoving air bubble. The initial part of phacoemulsification is uneventful for the eye, though it's causing a progressive DM strip. During the later part, a portion of decimes is caught in the phaco tip. Here it is fully stripped and extruded from the eye. The arcuate line on the cornea on retroillumination indicates the nude area of DM strip. There is cross-sectional edema on the first day, but the endothelial cells cover the stripped area over the weeks, fortunately in this case. The anterior lens capsule is the next membrane encountered. Most femtorhexis are free-floating. Some may be tethered to the capsule at points. Such incomplete rhexis need to be manually completed, including all the laser spots in the flap to be pulled out along with the outgoing flap. Non-adherence to this tenet can lead to ALC tags that can go onto PCRs. Now coming to the posterior capsule. Here is an incomplete rhexis that has been pulled out without realizing that fact. This has caused a tag in the region between the left side port and section. Though all the initial steps are uneventful, during cortical wash, the tag gets caught in the aspiration tip and is pulled. This leads to a linear posterior capsular tear up to the mid-center of the posterior capsule. Fortunately, the fornices of the bag are well supported. There is no vitreous and no further extension of the tear, allowing the IOL to be placed in the bag stably. Flax is therefore a sophisticated surgery that warrants delicate handling of all natural intraocular interfaces and membranes.
Yes, yes, Swapna, that was again different videos which you showed us. Now, I really would want to know, can Dr. Anand, yes, I would really want to know, it's pretty difficult to create a DMD on a femtocataract platform. Was there some predisposing factor in this particular eye, any history of injury, or is it that when you took your instrument to open the incision, open up the incision, you inadvertently created the DM detachment? You have an explanation for that?
Yes, ma'am. I had gone back and checked all the cases. I mean, we took out videos from the previous femto procedures done from the laser backup. And we saw that such DM bubbles are not uncommon, actually. But in this particular lady, there was a very low ECD. Very low in the sense it was in the range of 1,300. And that could be one of the factors, because this is the only case where there was actually such a large DM strip and peeling of the entire membrane that happened in my hands of all the cases that I've done so far. So she had a really low endothelial cell count density, and I think that unhealthy adhesion between the DM and the endothelium could be responsible for the strip happening is the hypothesis. Though such DM detachments do happen during femto cataracts, especially at the sections. And if you go back and check all your videos, you can see small air bubbles happening here and there, either at the side port or the main section. But most of them, and maybe none of them, turn out to be DM strips unless the endothelium is very unhealthy.
I think, Dr. Swapna, you have hit the nail on the head. The only thing is that since now you are alive to this fact that when you see this air bubble, there is a plane that has been created. See, when you get this lamellar separation that is happening, it is not something which is very controlled. You cannot actually control it. Nobody can control it. So it's wherever it goes, it finds the plane of least resistance, it goes. And what you are saying is an unhealthy descent. That is where it goes. But since you had seen a large blob of air, it would have been more prudent at that particular time. Maybe for future one learns that you should try to respect that place very significantly, and maybe actually you could have the air bubble come out, because there is a plane and a track that is there from where the air bubble can actually be pushed out. So that is something, because if you hold it, it is going to cause a problem. So that is very, very important under those circumstances. I really don't know. There is a technique. I'm just thinking. I'm speaking as I'm thinking. Described a technique of putting a contact lens and then doing the surgery and taking it out. I really don't know whether that could. But huge bubble that you could see. And
yes, you're very right. So only thing, all this was in retrospect. So
I understand.
When I went over the video 10 times, that I realized that unmoving air bubble is in the lamella. Otherwise, you think it is one of those bubbles that come into the anterior chamber. Nothing bad ever happens to you, So that kind of security was there at that time.
So Dr. Swapna,
all of us take, because this is a typical look of a bubble which is going and separating out the descents. And there's nothing you could have done or anybody could have done. The only thing is you should have been alive to it. Now that you have reviewed it, you have done a post-mortem or whatever it is. Under those circumstances, what we have to show to the audience or to the people is that once you have such a thing, and once it is this big, you need to be very, very careful about the whole thing, that this will be a potential DMD.
So how do you manage it now, sir? How do you manage it now that we know it?
See, basically, I would disregard this incision and maybe make another incision.
Make another incision.
No, the bubble is already there. You have to remove that. Right? You inject viscoelastic and squeeze it out.
Yeah, that's what I said. You could squeeze it out and disregard that. I would not open that incision, because that incision is fraud. And
or at least not open it with a blunt instrument.
No. I think what sir is saying is right. Squeeze it out with viscoelastic, do a visco expression, just squeeze out the bull, and then create another opening, and maybe with a sharp instrument, with a normal blade.
Or worst case scenario, inject C3F8 gas. And
of course, C3F8 will also do the work. Yeah, of course. That's the ultimate. That's what we usually do.
Yeah.
Nice videos, Swapna. I think just reiterates the fact that we have to, though we have all invested on the laser, we should stop using it for creating incisions.
Yeah.
I kept struggling with it initially. I thought I paid so much I should create incisions.
Yeah.
But now I've stuck to my blades and I get it exactly where I want, a limbal incision, 2.4 millimeters, and no struggling with this thing and trying to open it up. Sometimes it's so uncontrolled. You have an arcus, it doesn't open up. I think this is one more reason. But as far as the other parts are concerned, I think I completely agree with you. That's the reason with any white cataract, mature cataract, I always stain the capsules and look for those tags or areas where there's no neck. And nowadays, previously, I used to use a down-up technique to pick up the rhexis, but now I go with a Sinski hook to the side port and just gather it up in the center. And any small tags that is there, that's taken care of. Of course, if you find any large uncut area, then you go in with a assist it home and usually do the conventional rhexis. And with both the machines, whether it's lenses, catalyst, I'm not sure about the LENSAR and other things. I think these situations are do occur once in a while, and we should be alive with the fact. But I think internationally, people are giving up using the lasers for creating incisions, and we are not doing anything wrong to the patients by doing that.
No, but Ram, your frank opinion, I don't know, Swapna is a loyalist, she's stuck on to the Lensex still, but are we not getting less of these capsular problems with the catalyst?
No, absolutely. I just want
I was wondering, Maipal, how you didn't bring this up.
Yeah. No, I wanted to ask the same question to Swapna. They're using Lensex.
You took a long time in bringing it up, Maipal. I mean, no.
Amurthy, we have not had this problem with the catalyst and all this rhexis problem.
Huh?
We have not had this problem with the catalyst.
No. I have a catalyst. I have a Lensex. Initially, I was using it. It's there in one of my centers. Even with catalyst, of course, it creates a much faster rhexis. It creates in 1 second. But once in a while, we do have tags on the catalyst also.
Once in a while and every while is a different thing.
No. It was not happening every while.
Don't remain. The important take-home message is that whether you use catalyst or Lensex, in a mature cataract, look for skip areas.
Yes.
Skip areas are going to be there. So put blue Rex, then identify where your rhexis is, where are the attachments, and try to do a slow rhexis in that area. So this will prevent a major problem.
That is why you became the president of Tamil Nadu.
Thank you very much. I'm going
You see a lot of air bubbles
become the president of the All India also.
All the best, man. All the best.
You see a lot of air bubbles collected under the place where the membrane has not been cut. So you'll find those small bubbles which are indicative that
which is
there are.
Yeah.
You're talking about the rhexis?
No.
Yeah, the rhexis.
Okay.
Yeah, those small bubbles. We don't.
Are you still creating incisions with the laser?
It's hard because now it comes exactly at the limbus. Earlier, my problem was that it was way into the cornea before they, actually fixed it. But now it's exactly at the limbus. So I'm,
Which is fine. Our next speaker is Dr. Wonderful, Swapna. Enjoyed having you here. Though you could have joined in